Welcome, and thank you for joining us. My name is Christine Hamp, President of the National Grange. I am very pleased to welcome you to this webinar presented by the National Grange and Rural Minds and sponsored by Grange Advocacy. Since our founding in 1867, the National Grange has worked to advance the political, economic, and social interests of the nation's farmers and all engaged in agriculture. Today, we remain active in legislative advocacy to represent the interests of Grange members and others who live in rural America. While the information being presented today about Medicare prescription drug coverage changes under the Inflation Reduction Act is relevant to many people, it's especially important for Medicare beneficiaries living in rural America. As you'll hear, these folks may experience significant changes to plan premiums, formularies, and access to treatments as a result of the Medicare Part D benefit redesign. We appreciate our longtime partnership with Rural Minds as we work together to improve the state of mental health in rural communities across the country and address rural mental health inequity. Overall health includes mental health, and insurance to get the care and treatment that's needed to stay healthy is a priority for the Grange and Rural Minds, as I'm sure it is for all of you. Thank you for joining us today. I'll now turn it over to Rural Minds Executive Director, Chuck Strand.
Thank you, Christine. Rural Minds is the only national nonprofit focused solely on providing the 46 million people in rural America with free information and resources to confront rural mental health challenges and the stigma that surrounds mental illness. This webinar is the first in a series of 3 webinars about Medicare insurance coverage changes, along with importance of pharmacies across rural America. We recognize that adequate healthcare insurance is necessary to minimize the anxiety and stress from managing a physical illness, a mental illness, or both. This 45-minute webinar will feature a presentation from Joel White, President of the Council for Affordable Health Coverage, which will be followed by a Q&A session moderated by Judith Gorsuch, a healthcare consultant with Hart Health Strategies in Washington, D.C. By way of housekeeping, we respect the privacy of everyone who is watching this webinar, and therefore your name and image will not be visible to others in the webinar audience. Please enter any questions that you have in the Q&A box. We will answer as many as possible. Also, if at any time you or someone you know is experiencing a mental health crisis, call 988 to speak with a trained mental health counselor at the National Suicide Prevention Lifeline. At this time, I'm pleased to introduce Joel White, President of the Council for Affordable Health Coverage, and its campaigns on transparency and medication adherence, Campaign for Transformative Therapies. Joel spent 12 years on Capitol Hill as professional staff, where he helped enact 9 laws, including the 2002 Trade Act, which created healthcare tax credits, the 2003 law that established the Medicare prescription drug benefit and health savings accounts, the 2005 Deficit Reduction Act, and the 2006 Tax Relief and Healthcare Act, which reformed Medicare payment policies. He served 6 years as staff on the Committee of Ways and Means, first as professional staff and then as staff director of the Health Subcommittee. Prior to his work on the Committee on Ways and Means staff, Joel worked for Congressman Jim Greenwood of Pennsylvania for 2 years and Congressman Chris Shays of Connecticut for 4 years. He's also the co-author of the book Facts and Figures on Government Finance, which brings together data on public finance at all levels of government with comparisons of taxing and spending levels spanning a half century. He holds a BS in economics from American University and is a member of the National Economists Club. Please join me in welcoming Joel White.
Thank you, Chuck. Really appreciate being here today and taking the time to talk a little bit about a complicated but important subject, which is what's happening with Medicare, and specifically the impact of the Inflation Reduction Act, some of the changes that are going to be felt now and in a little while, and what you might do about it. So wanted to start off by sharing a few slides. This is a complicated subject. It is an important subject, and we wanted to just jump right in and talk a little bit about what's happening in the Medicare program and how it might affect you and what you might do about it. Just a little bit very quickly about us, CHC. We are a nonprofit, nonpartisan coalition in Washington, D.C. We've been around since 2001. Our whole goal is to make sure all Americans have access to affordable coverage. And Medicare is a critical part of that access. And like I mentioned, is changing quite a bit. So today, our main objectives are to just briefly review the basics of Medicare and then learn about those changes that the Inflation Reduction Act is making, and then understand what that impact is having, particularly on people in rural areas and perhaps with mental illnesses. Right now, I think the main messages you should take away from this webinar is that beneficiaries love Part D. Part D has been a source of secure and affordable prescription drug coverage since 2006 in the Medicare program. As Chuck mentioned, I helped write that law in 2003, and it's over-delivered in terms of lower premiums, beneficiary satisfaction, access to drugs, robust coverage. And that's been a great success. But I think the Inflation Reduction Act did radically change the program. And it's that those changes are in some cases very beneficial, in some cases not so much. And those changes are now coming online in terms of their being effective. And we wanted to talk about the good, the bad, and the ugly. And then lastly, there are ways that you can protect yourself from higher premiums and higher out-of-pocket costs. And there are ways that you can weigh in with Congress and the administration to ensure the law is improved so that some of those bad things are mitigated or turned into good things. So let's dive right into it. I wanted to talk about first just some Medicare basics. Part A is the part of the Medicare program that covers most of your building type stuff. So when I say buildings, I mean hospitals, nursing homes, maybe hospice care, and some home health care. Part B is all about people. So Part B covers doctor visits, outpatient care, maybe chemotherapy, medical supplies, things like that that are delivered in a physician office typically. In Part C, those are the privately administered plans. So the government is contracting with an insurer to deliver all the Part A and B benefits, and in some cases, prescription drugs that you get at a pharmacy counter. So that's comprehensive coverage. And in some cases, those plans provide additional benefits like eye care, dental care, et cetera. And then Part D is really the main program to deliver outpatient prescription medications. These are typically drugs that you get at a pharmacy counter, and you pay maybe a copayment for. They're also contracted by the federal government with private insurers to deliver that benefit. And the important thing there is that the program is voluntary. So it's voluntary for beneficiaries to sign up for, and it's also voluntary for plans to participate in the market and offer that coverage to seniors. There's a broad choice of plans in the marketplace today. I think the average beneficiary has access to about 21 different plans, although those choices are going down. Part D is a well-constructed law. And by that, I mean it has consistently come in under budget, under taxpayer budget. So taxpayers are spending less every year because the program is designed in a way to set up competition to make costs go down. There have been low and stable premiums for a long period of time, more than 10 years. Basically, the premium has stayed relatively the same, the average premium. And that's changing as well. There has been good access to drugs and to pharmacies to get those benefits. Although in the past 5 years, what we've seen is more plans are really taking the opportunity to restrict access by narrowing the number of covered drugs or by narrowing the process by which patients get those drugs through prior authorization or step therapy or things like that. And I think at the end of the day, the key measure of success is this program has a 90% satisfaction rate. People really love the Medicare Part D program. because I think it over delivers at a low cost that is affordable for most. So we want to talk a little bit about how the Inflation Reduction Act is changing things. And here it's in the healthcare side, at least in Medicare, four primary areas: Medicare inflation rebates, Medicare, the new Medicare drug negotiation program, which I think is a bit misnamed because really it's all about setting drug prices. The third area is Part D redesign, and that means that the benefit that seniors can sign up for on a voluntary basis is changing in significant ways, and it's becoming much more generous. And that's a good thing for a lot of people who have either high costs or can't afford maybe upfront costs at the beginning of the year, or have trouble paying for insulin or vaccines, for example. And then I think it's important to note the Inflation Reduction Act was a big bill. You'll see the image here. The first part there is corporate tax reform. So this bill actually changed a lot of taxes. It created new tax incentives for green energy initiatives and enhanced Obamacare subsidies. And one of the downsides of the law is that it really took about $300 billion from Medicare and spent it on those other things. And that means that some of what we're seeing in the market with higher premiums, maybe higher cost sharing, could have been mitigated if that money had stayed in Medicare. So that's a lot to cover in just a few minutes here. So we're going to get into it, and it's going to be complicated, but hopefully I'll do my best to keep things simple. So this is a timeline of the different changes. And you don't need to memorize this. I'm going to get into the high points, but basically this was a complicated law. And you can see the high points here. If you start in 2024, beneficiaries would pay cost sharing for very high costs above a threshold at 5%. And that cost sharing went away in 2024. In addition, in 2024, there was some extra help provided for more seniors at the bottom end of the income ladder. And that's really important because I think in many rural areas, and I'm from a rural area, from a small town in Connecticut of 10,000 people, there's a lot of lower income people who benefit from that extra help. And basically what that means is your premium is covered fully, and your cost sharing is reduced. And so you have better coverage, recognizing that lower income folks sometimes have challenges accessing benefits. And then in 2025, the big change happens, and that is seniors and the disabled won't pay more than $2,000 out of their pocket for prescription drugs. But it comes with some important changes, shifting risk between plans and taxpayers and beneficiaries. But beneficiaries can also smooth their cost sharing throughout the year. We'll talk a little bit more about that in a bit. But then in 2026, a sea change happens, and that is for the first time, the government is going to set prices in the Part D program, which I think changes the program in significant and fundamental ways. And we'll talk a little bit more about that. So that's the high level overview, kind of the timeline of where we're at and where the next few changes, important changes are coming. So the first thing I mentioned was Medicare inflation rebates. And I'll just talk about this very briefly. Basically, if a drug manufacturer increases prices by more than inflation, they have to pay back the difference to taxpayers, to the Medicare program. So that difference is basically the number of drugs they sold and the price difference. So in this example, if I sold one pill, I would owe $20 in a rebate. So, and the important thing here is that the beneficiary's cost sharing is based on the $110, not the $130 that you see in this graph here. And I think that this is calculated on a quarterly basis, and every quarter the administration puts out a press release talking about how this provision alone is saving folks on their cost sharing. But some also argue that this provision creates incentives for higher launch prices, which actually goes in the other direction. So that was a big change in the Medicare program. It saved quite a bit of money and it's just now playing out in Part D as of last year. So onto the drug price negotiation program. And the thing to keep in mind here is that there's some challenges with prescription drug prices, but seniors pay their premium to a health plan to provide drug coverage so that all they should pay is a out-of-pocket cost. And so the thought behind the drug price negotiation program was that the plans weren't doing a good enough job negotiating these prices on their own. So the government had to come in and set those prices. And I, having worked on the law initially, thought that was a mistake. I thought that the plans were negotiating discounts of 20 to 90% on certain drugs. I think the real challenge with what was happening in Medicare was that the plans weren't then passing those full discounts on to the patient so that they would actually benefit at the end of the day. So we created a solution to get the government more involved that'll get the government, I think, more in between the patient and their treatment and care, which is unfortunate. But let me explain this part of the program quick, and then we'll get on to benefit redesign. So basically what Medicare does is they look at every drug that's covered in Medicare that's been approved for at least 7 years on the pill side or 11 years on the biologic side, or products that are typically maybe infused or injected at a physician office. And then it takes out drugs that are in certain categories. So orphan drugs are drugs for people with rare diseases, or drugs that maybe not very expensive or derived from plasma. And then it arrays those drugs or lines them up based on their total expenditures, first in Medicare Part D and then in Medicare Part B, which remember is the physician office, and says, okay, what are the highest cost drugs? And so in 2026, the government identifies the 10 highest spend Part D drugs. In 27, they'll do 15. In 28, they'll do another 15. In 29, they'll do 20. But they look at those 10 highest spend drugs and they say, okay, these are the drugs that will be selected for the negotiation program. And the important thing here is to know that that is a cumulative list, that is going to grow over time to where most Medicare drugs will probably be in this negotiation program. So this happened last year or earlier this year. These are the 10 drugs you can see there, most of them for treatment of heart disease, heart issues, diabetes, rheumatoid arthritis, and insulins. And so several on the products of the list kind of made us scratch our heads, but these were the ones that were selected. Again, you can see the total price there in the chart, or total cost to Medicare. That's not a net cost, it's a gross cost. And some of those products on the list are kind of puzzling, and I'm happy to answer questions about the specific drugs that were selected. But these are the ones that are going to be subject to this new price, quote unquote, negotiation program. And basically, HHS is now in the process of a back and forth with manufacturers to determine a final price that should be available in the Medicare program. And basically, it's based on the time that product has been on the market. So you can see here the first category, short monopoly drugs, 11 years after approval. There's a ceiling or a cap or a control on that drug's price of 75% based on what's known as the non-federal average manufacturer price. You don't need to know what that is. Just know that there's a cap that you can't go above for the product based on the length of time it's been on the market. Now, what HHS can do is it can negotiate or lower the price or have a final offer for as little as a penny in the Medicare program. But it does have to take certain things into consideration, like cost of research, condition, illness, patient access, and things like that. But it's not a normal negotiation. If a manufacturer wanted to say, I don't want to participate, HHS says, sorry, here's our final offer, take it or leave it, and they leave it, they would basically owe a tax on every product sold in the US of 186%, starting out at 186%, which means you're losing money on every drug you sell in America. Or you can leave the Medicare and Medicaid program, which would result in dramatic patient access issues across all conditions. And then you can see how that ceiling over time goes from 75 to 65 to 40%. The thinking here is that if a drug is on the market for that long without competition, the price should get lower and lower. And the only way you get off this list is if a competitor comes on the market, a generic or biosimilar comes on the market. But if you have two Hart products that compete with each other on the branded side, those can stay on the list kind of in perpetuity. So once a generic competitor comes on the market, that's the only way to get off the list in this program. So one of the challenges that we see with this scheme is that there's a different time frame for large molecule biological products who face price setting after 13 years after FDA approval, and small molecule drugs that face price setting 9 years after FDA approval. So if you're a drug manufacturer, you obviously want more time before price controls take effect. So you're going to shift your resources and shift your R&D budget into those biologic products. Well, what are those? They're basically infused or injected, typically in a physician office or clinic or hospital. And so that has real implications for people in rural communities who may not have a lot of access to even a physician, but certainly not a hospital or a clinic nearby that could infuse that product. And so who are we talking about here? This is cancer patients primarily, or people with eye conditions or other illnesses. And so as we see research dollars kind of flow into these biologics, the other thing we're seeing is this has implications for clinical care. And for people with mental illnesses in particular, we need products that can cross the blood-brain barrier. And those are small molecule products. Those are not large molecule products. And so what we're seeing is, just as a result of this one example, the difference in time before those price controls take effect, significant implications for people in rural communities and significant implications for people with mental and other illnesses. I think access to a pharmacy is robust. My hometown, little town of Woodbury, we've got 2 pharmacies in that town. We've got one doctor, she's a primary care doc. We have no specialists. So no one in my little town of Woodbury would infuse chemotherapy. Where I'm from, I would have to drive to Waterbury in order to get chemotherapy if I had cancer. So this is a big problem. We've got bipartisan legislation that was introduced to fix this. The EPIC Act, bipartisan, Murphy, Davis, and Guthrie. And the hope is that we can get this timing challenge corrected in a timely way. And I'll tell you how you can help with that in a little bit. So the timeline is complicated. I don't want to spend a lot of time on this, but basically we're right in the middle of the program. And if you look at September 1, 2024, at some point before that date, on or before that date, HHS will publish their maximum price list. And so we're going to be hearing a lot about this in August and September, about how we're significantly lowering drug prices. But I want to keep people focused on the fact that most seniors, if you're enrolled in the Part D program, you're not just going to the drug manufacturer to pay a price. You're going to an insurer and paying a premium to get coverage for those drugs. And so even with this price-controlled scheme, it may seem like people would be benefiting, but that depends highly on how your coverage responds, or what's available in the market for you to get your insurance to cover these drugs. And so that's what I want to talk about and spend the rest of the time on now, Medicare benefit redesign. And I think the thing to understand about this is that the IRA had some really good changes and some other changes like the price controls, which are leading to significant market disruption. So the first thing is, starting in 2025, no senior will pay more than $2,000 out of pocket per year. That is a significant change down from the $3,250 they pay this year. The other thing is, if you have high costs up front and maybe you're lower income and can't afford those, the legislation allows you to smooth or spread those costs out over the year so that you're not faced with a tough January or February or March. And then finally, I mentioned insulin capped at $35 a month. That happened last year. Zero cost vaccines that have been diagnosed as preventable. And then on the higher cost side, though, what we're seeing this year and expecting next year is significantly higher premiums. We're also seeing fewer plan choices and a consolidation of the insurers in the marketplace that are offering those plans. We're seeing higher cost sharing, less access to drugs, tighter drug lists available on these plans, and then more aggressive use of management techniques like prior authorization or step therapy that makes it much more difficult for people to access their therapy at the pharmacy counter. And obviously, a result of price controls, you have less R&D, you have fewer innovative products. That has an impact on healthcare and your access to it. So this is where things get complicated, and I want to stress here the details and the different levels I wouldn't pay attention to. What I would look at is the colors. And so starting at 2023 and then working down, what we basically have is a reduction in the orange. Well, what does that mean? It means patients are paying less over time. The other thing we notice as we go from 2023 down to 2025, we have a lot more blue, and that means the insurers are taking on more risk. And then the third thing I would mention, going down from 2023 to 2025, the dark blue gets less, and that's the taxpayer Medicare subsidy on the high cost end. For people who are sick and maybe taking expensive medications. So the three things: beneficiary costs are going down, plan responsibility is going up, and taxpayer or Medicare subsidies are going down at the high cost end. And so as we think about those changes, as I mentioned in 23, insulin capped $35 a month, zero cost sharing for vaccines. In 2024, if you notice that 5% that the beneficiary used to pay above the high cost line is eliminated, right? But that's put on the plan. But beneficiaries no longer have to pay anything after $32.50 in costs. But then in 2025, what we're seeing is a much more simpler benefit where the beneficiary pays their upfront deductible, $590. And then spends 25% of the next cost up to $2,000. And once you hit that $2,000, though, you're done. A closer look at what that looks like at the back end, the high cost end, the catastrophic end, is those taxpayer costs, again, the dark blue, going down, right? Going from 80% to 20% in 2025. The beneficiary costs eliminated in 2024 used to be 5%. And then the plan costs moving from 15% to 20% to 60%. And then the new category in 2025, where a drug manufacturer is going to pay a 20% rebate or discount on costs above $2,000. So this rejiggering of risk, or the reinsurance it's called, is really having significant implications for the market. And we'll talk about that impact in a second, but I wanted to spend a little bit of time on the patient smoothing option. And so starting in 2025, beneficiaries will have an option to pay cost sharing in monthly payments, again, to smooth out those costs over time. And you can see here, instead of maybe paying $500 right at the front end for a product that would take them until April, they would hit the $2,000 out-of-pocket limit. You can see here the green with the M3P smoothing, the patient smoothing provision. They can pay over time, and that makes it more manageable. It's a more manageable benefit. You've got to opt into this program. It's not automatic. So if you think you have high costs up front, or maybe you struggle paying for those costs, it's definitely something you want to check out with your health insurer starting during open enrollment beginning in October. The last thing I would just want to mention in the redesign category is that there was significant additional help provided to low-income beneficiaries. So everyone with income below 150% of poverty now is eligible for the extra help program. What that means is you basically get your premiums fully paid, reductions in cost sharing, and better access to drugs. So that risk that I talked about, the rejiggering, how are all these changes kind of playing out in the marketplace? And this is what you really need to pay attention to heading into October. This is shocking to me. These are average premium percentage increases in average monthly premiums. Premiums have been low and stable for a long period of time. We don't see this in other healthcare programs, but basically always less than 10%, except in 2009, until we hit this year, and there was a 21.5% premium increase. And some are projecting, ourselves included, that we could see 100% premium increase in 2025. People will start shopping for those plans on October 1st. The second thing that we're seeing is a significant reduction in the number of plans available, the choices available in each area for people to voluntarily sign up for. So first year of the program, 2006, we had about 1,400 plans. We have basically half that today. And we've got a consolidation of plans in the marketplace at the national level with just 21 plans now. And the low income, the extra help plans are also being reduced. Again, less than half from our first year. That's significant because if I want that $0 premium, I've got to find what's known as an LIS benchmark plan. And there's only 3 left to a given beneficiary. So those plans are also becoming less available. And people need to shop for that if they want to sign up for that extra help benefit. So just want to talk a little bit about the timing. So we're right here in July, and basically in February and April, they put out the regulatory rules to make the benefit known for next year. In July, the end of this month, we are expecting CMS to come out with what's called the base beneficiary premium. And again, we're expecting maybe a doubling or more of premiums. In September, as I mentioned, CMS will announce the prices in the drug price negotiation program. But then in October, September, October, seniors will get in the mail what's called an ANOC, and that's an advance notice of coverage. That letter will basically say, hey, your plan's changing in a significant way. Your benefits are going down, your premiums may be going up, maybe the plan's not available in your area anymore. You're going to have to shop for a new plan. And that plan stop shopping, you can go to Medicare.gov and start taking a look at your benefits, what's available in the marketplace on October 1st, and you can start signing up on October 15th. And that open enrollment period lasts all the way through December 7th. And again, we are expecting a doubling of premiums, reduced plan choices, tighter formularies, which means less drugs on the list that the plan will actually cover, more utilization management, more prior authorization, more step therapy, and more cost sharing. And I think one of the significant things about having less plans in the marketplace, especially if a lot of plans start to get out, for example, Mutual of Omaha, which plays big in rural areas, already announced that they won't be in the program in 2025. So for Montana, Iowa, Nevada, Utah, 500,000 beneficiaries who are enrolled in that plan, Oklahoma, another big state for Mutual. they're going to have to find a new plan and shop starting on October 1st. And they may be surprised by what's available. And the challenge I think that we see is the financial dynamics are such that maybe more and more plans decide not to participate in Part D, which means we could actually see some areas of the country, particularly rural areas, that may be bare or not have a plan available to beneficiaries. What happens in that case is the government steps in and runs the plan. And the government can decide what drugs are covered or not covered, and how all that works. And so it's a very real challenge. The other thing we're seeing, I think, just very quickly on the management issue, there was a May 2024 survey that came out that said 97% of plans saying that they were likely or somewhat likely to really make restrictions on access to drugs. And 87% of plans said they were likely or somewhat likely to deny coverage of new medicines that compete against the government price-controlled products. So plans are looking at this market and they're trying to figure out how can they manage the risk. And a lot of the strategies are either raise the premium, get out of the market, or really clamp down on access and make patients' lives miserable by going through these hoops and hurdles. So it's a big challenge. We're keeping a close eye on the market, but I think one of the things I wanted to provide is a little bit of practical advice. Maybe the first thing is protect yourself. Talk to an expert advisor. Go talk to your local insurance agent or broker to ask them what should you do. And they're required by law to give you their best advice about which plan works best for you. Second thing is consider shopping for a lower cost plan. Go on Medicare.gov, take a look at the options there. If you don't have access to the internet or an expert advisor, you can go to the state. There's a state health navigators and experts who can walk you through the program. The third thing is consider signing up for the Extra Help program. If you think you qualify, contact Social Security or Medicare. Every state has an office, or you can call the 1-800 number or go to the websites and figure out if you qualify. Generally, you have to have income less than about $28,000. It varies by geography, but consider that Extra Help program. And then consider opting into the patient smoothing program. I think that is a great option for people with high costs, especially at the beginning of the year, where they can smooth that out over time. But the second thing is more on what can you do with the law itself. And I contact your member of Congress, meet with them when they're back home in the state, and just weigh in with them. Every member of Congress has an email address. Every member of Congress has a phone. Pick up the phone, call them, meet with them in district, and tell them that the IRA has some significant flaws that need to be fixed. Stop the rate on Medicare. When you save money in Medicare, keep that money in Medicare. Prevent these massive premium increases. And really, I think the drug price controls are going to lead to access problems and challenges. Pass the EPIC Act and replace those price controls with mandatory discounts. And then require plans really to do what they're signed up to do, contracted with the federal government to do, which is to maintain access to drugs affordably. And then if you're interested, join our advocacy campaign. We're working with Congress and the administration to make sure all of these things don't kind of blow up and that we can continue to maintain Part D in an affordable and accessible way. You can go to our website, it's listed there, or if you're interested in becoming an advocate, email Shannon McGurl. And you get timely updates on what's happening, and we're happy to schedule in-district events with members of Congress so that you can have your voice heard. So appreciate your time today. I know I covered a lot of ground. It's a complicated subject, but something I'm deeply passionate about. And as someone from a rural area, really appreciate how important this is to so many people all across our country. Thank you.
Thank you, Joel. So with that, we have time for some questions, and I just want to acknowledge for folks too that a recording will be sent out. So I know there was a lot of information given, so if you want to watch it a second or third time, that will be available. Or if you need to jump, you will have access to all of this afterwards as well. Joel, I think the first question is the $2,000 out-of-pocket cap is very interesting to a lot of people. If I'm a beneficiary and I think I'll benefit from that, is that something that I need to enroll in, like with the smoothing? And do I need to track my own spending? And is it all of my prescription spending or just the part that I spend? Kind of what are like the mechanics of that?
Yeah, great questions. So you kind of have to sign up for it. It's when you sign up for a Part D plan, this comes with it. This is automatic. You don't have to do anything extra other than just you sign up for a plan. This is now part of the program. So you don't have to do a special form or anything else like that. So if you're already in Part D and you're going to stay where you're at, you'll get automatically re-enrolled into your plan next year. As soon as that happens next year, it's $2,000. You're limited out of pocket. So no additional sign up. That is significant because after you pay that deductible, you're going to pay 25% of the cost of the drugs up to that $2,000 and then nothing more, which is a huge benefit. About 1.5 million people are going to benefit from that and more over time. But you don't need to do anything special. It just comes with the program now.
Great, thank you. And then we have a question about just acknowledging the complexity of the IRA. And the person's asking, does the law force these companies to essentially tie their prices to prices charged outside of the United States, which are typically tend to be lower than what's charged here?
I missed the first part of the first part of the question.
The first part was just the person said the IRA is very complex, which I think, yes, that's very true. And then they just asked, is it tied to foreign pricing, essentially?
No, it's not tied to foreign pricing. What it's tied to, and one of the challenges we saw with one of the issues we thought about when we originally created Part D was we really didn't want the government to be involved in these pricing decisions. We didn't want them involved in the coverage decisions really either. And we didn't want the government to get in between the patient and their doctor in determining what's the best treatment here, which is why we said the federal government will hire these plans to negotiate lower drug prices with manufacturers. And then those lower prices and discounts should be passed through to the patient. And that model worked for a long time until what increasingly became understood is that the plans were negotiating with the drug manufacturers, but they were no longer passing those price concessions to the patient. And so the program got kind of screwed up at the contract level. And I know some have said, well, we should then have the government set the price or look at what France or Germany or Canada is doing and adopt their price. I think if we went back to the original intent, which is the plan negotiates with the manufacturer and then the plan provides those discounts to the patient, we'd all be better off. But nothing in the IRA is about those international prices. It's just some bureaucrat sitting at HHS figures out what they think the price should be. And it's maybe informed, maybe not, we don't know, but it's now in the hands of politicians and bureaucrats who are setting the price at the end of the day.
Thank you. And I think we'll have time we'll squeeze in one more before I turn it back over to Chuck. What impact, if any, is the outcome of the upcoming presidential election going to have on everything you've just described today?
Yeah, so I think it's important to note the benefit redesign is bipartisan, right? Democrats supported that, Republicans supported that. So I think that part of the program is probably going to be with us for a long time. I think there's some changes that need to be made there, but I do think that Republicans and Democrats have a very different view of the government's role in healthcare. And I think what the Democrats have said is that they want to do more price controls and they want to accelerate that in Medicare, and they want to put those price controls in the private sector. and they want to take that $2,000 cap that's maybe driving premiums up and put that on employers and union plans and farm plans and co-ops and things like that. That'll really spike premiums. And I think that that would cause a lot more people to have to go to Medicaid or Obamacare. On the Republican side, I think what we hear a lot from Donald Trump and others is we should have the price that it's available in France. And so I think that's also a bad idea because France isn't paying their fair share. Just like in, he talks about NATO not paying their fair share. They're not paying their fair share on drugs, which is why our prices may be more expensive. So we need to address that international difference. I think there's better ways to lower drug costs, right? Like we need coverage that works for us. We need market-based incentives that are getting more products to the market quicker so that we have price competition, which means we need to reform the FDA. And there's probably 900 other things that we could do. But I think the elections, it's a clear difference, right? Like it's one where the one group wants to say the government should run things, and another group is more inclined to say, well, we want innovation, we want private sector incentives to help drive down the costs.
Thank you. And I just was told we can go a little bit over because we're getting a lot of great questions. And again, if you do need to jump, we will make this recording available for you so you can hear the questions that came after you left. But one other question is, how will these changes you described specifically impact Medicare Advantage or Part C of Medicare?
Yeah. Similar dynamic there. So all of the $2,000 cap, all that stuff kind of carries over to Medicare Advantage. And we're seeing a similar cost trend in Medicare Advantage. It's just less. So the average premium increase in D was 21.5% in 2024. The average premium increase in Medicare Advantage was 5%. Okay. So what Medicare Advantage is able to do that Part D plans are not able to do is they take what's called supplemental rebates or an additional bucket of money, and they're able to buy down beneficiary premiums to make the premium look less in Medicare Advantage. So that, I think, because there's a difference now between Part D premiums are increasing up here, Medicare Advantage is increasing up here, more people will take a look at those differentials and want to sign up for Medicare Advantage. So it will accelerate the desire, and I believe the trend, to have more beneficiaries in Medicare Advantage. Now, the trade-off there is if you're in Part D, you're in fee-for-service, you can go see any doctor you want, any hospital you want, any provider you want, assuming they accept Medicare. Medicare Advantage, you're managed, right? You got to go to the guy in the network. And sometimes that's really difficult in rural areas to find all the doctors you want to see in the same network. And so that's kind of the trade-off.
Yeah, that makes sense. And I think this question was triggered by the fact that you mentioned pharmaceutical companies can pull out of Medicare if they don't want to participate in this negotiation program, which is not really a viable option. So the question is sort of on the flip side, are Part D providers, and I think the person means insurance plans, are they allowed to just drop out of Medicare while still competing in the private market?
Yes, they can. And again, Mutual of Omaha is already out. If you're in Missouri, KC Blue in Medicare Advantage has already announced they're going to pull out in 2025. So, the law is driving this disruption, I think. We'll see more plans get out, but once they pull out of the Part D market or Medicare Advantage market, they can still offer benefits in the private sector to employers on Obamacare, things like that. Now, they can't jump back in. So if you pull out of Medicare Part D, you've got to wait a couple of years before you get back into the market in that area. The incentives, I think, are going to continue to be consolidation of the market, fewer plan choices, more like I've only got one plan in my area, so I don't really have a choice. which is tough because we want a robust market. We want people, the different choice of plans, because some plans offer $0 premium. That's going away. $0 deductibles probably going away. People used to pay a lot more co-pays than percentage-based co-insurance. That's probably changing to mostly co-insurance. So 25% on a $100 drug is a lot more than $10 at the pharmacy counter. So it's just getting to be a much more expensive market with fewer choices.
And in terms of other long-term, potentially unintended consequences of the new negotiation program, one question is, will this mean potentially that foreign-based drug companies will no longer make their medicines available in the US?
We're not seeing a lot of that yet. I think it's a possibility, but I would tend to doubt it because the US market is two things. It's large, right? And we're aging. And so you've got a lot of people who need those products. And every drug company I've ever talked to basically says the same thing. I'm in it to make money, certainly. But I've got a mission here. I want to cure cancer. I want to treat people with mental illnesses. I want to help people who are living with a rare condition. And so I don't think that changes just based on this bad thing that we've done in Medicare on prices.
Gotcha. And then someone flagged that insurance companies, like many others, get various tax breaks. What do you really mean when you say reduced resources for enrollment activities?
Yeah, so that's really on the insurance agent and broker side. If we're seeing fewer plans and higher premiums and plans actually getting out of the market, which means, well, if I don't have a plan anymore, I've actually got to go shop. And I may not know the best option available to me. Typically, I would direct people to an insurance agent or broker. They're experts. They're licensed every year. They've got to be licensed by the state and certified by Medicare. They've got to meet specific standards. Medicare earlier this year put out a rule that essentially reduced the reimbursement available to agents and brokers for enrollment activities. And so if you assume people are just like everyone else, if I pay less for something, I'm probably going to get less of that thing. And so at a time where Medicare, the plan world market is kind of in turmoil, at that same time when we need these experts, we're actually lowering resources available to those experts. So I think it's concerning. I hope people don't struggle to figure out what their best option is, but my concern is when we pay less, we get less.
Right. Another question about sort of secondary impacts. Do we know yet if this will have any impact on the AARP supplementals? Are those going to stay active, or is that just an unknown at this point?
I think it's an unknown. I mean, I would assume AARP will continue to be in the market. They've got brand recognition. There's lots of issues I have with AARP plans, but I think the general trend is if I'm in fee for service, I'm buying a standalone Part D plan, right? And usually those people will buy a Medicare supplemental plan, like an AARP MedSup, right? And if those plans the Part D plan is now very expensive to the point where I'm looking hard at Medicare Advantage and I want to get into a Medicare Advantage plan because it's cheaper for me. Once I get into Medicare Advantage, there's no reason for me to buy an AARP supplemental policy. It's all kind of in the Medicare Advantage plan. Now, well, let's just leave it at that.
Okay, and we are actually down to our last question. So, and this is a great one. Can states get involved to reduce the impact of some of these changes? Is there anything that state legislatures can do?
Yeah, so many states have prescription assistance programs for folks who are experiencing difficulties. They also have state navigators. They run like consumer navigation programs to help people figure out their options on the plan side. Also, states can help direct low-income people to the Extra Help program and get people enrolled and signed up. And I think it'll be interesting to see what states might do with the patient smoothing plan. I suspect not a lot, but there may be states that play in that. And then finally, I would say that, like, to the extent that there are, at the political side of things, policy side of things, to the extent that there are relationships, folks have relationships with governors or state legislators or mayors even, ask them to weigh in with Congress and say, like, look, if this market's getting hot and disruptive and we can't afford the premiums and my plan went away, there's a reason for that, right? Like this law is driving a lot of that disruption. And so contacting your member of Congress through that surrogate sometimes can be a louder voice than your own.
Well, thank you for your willingness to hang out with us a little bit past the end time. That actually gets us through our queue. So I will turn it back to Chuck to wrap us up.
Thanks, Judith.
Well, thanks again. And as we wrap up this webinar presentation, I would like to thank Joel White for providing us with this important information on the IRA updates to Medicare prescription drug coverage. Thank you also to Judith Gorsuch for sharing her expertise and moderating the Q&A. We thank our presenting partners at the National Grange, Christine Hamp, and our sponsor, Grange Advocacy. And of course, we thank all of you for joining us today and for extending your time with us a few minutes here. You can find more information about the National Grange at nationalgrange.org and access additional free mental health information and resources at ruralminds.org. Watch for the email with the link to the recorded content from this webinar and free registration for the next webinar in this series scheduled for Wednesday, August 21st. The topic will be the IRA's unintended consequences on development of mental health medications. Thanks again and take care.